Hi, welcome to this video of rare cases in cardiology related to reversible causes of dilated cardiomyopathy, part 1, presented by Dr. Kara Sliman. Let's start with this case of a man 28 years old who is obese. He presented palpitations. On ECG there is premature atrial contraction. On echocardiography there is a left ventricular dysfunction. He was normotensive with a BMI 29. The Holter shows excessive APC burden, 37%. There is no clear cutoff of APC which induce cardiomyopathy. It's about 20%. The APC appeared to be originating from the coronary sinus. On ECG, there is a negative P wave of the APC on LEDs D2, D3, and IVF, and on LEDs V4 to V6. There is an isoelectric P wave of the APC on LEDs D1, a positive P wave on LEDs AVL, AVR, and V1 to V3. On echocardiography, there is a dilatation of the left ventricle. The ejection fraction of the left ventricle is 40%. He did not support the beta blockers, so he was treated by ablation of the premature atrial contraction with a good evolution and normalization of the ejection fraction of the left ventricle 3 months later. The premature ventricle contractions can also induce cardiomyopathy. So what are the risk factors? PVC QRS duration more than 140 milliseconds. Interpolated PVC. The PVC doesn't change the interval RR. There is the same intervals RR. PVC burden more than 24%, PVC coupling intervals less than 600 milliseconds, epicardial origin. This is how to calculate the coupling interval of the PVC from the start of the normal QRS to the start of the PVC. This is how to recognize the epicardial origin of the PVC. We must calculate the maximum deflection index. It's equal to the time of the maximum deflection by the duration of the PVC. The cutoff is 0.55. In the right panel, the maximum deflection index is 0.56. So this is a PVC of epicardial origin. Another trick to recognize the epicardial origin of PVC, there is a large air wave in LEDs D2, D3, and IVF, and a large Q wave of the PVC in LEDs AVR, AVL, comparing with the PVC from endocard. This is a case of a man 21 years old with frequent PVC 31%, with left ventricular dysfunction. He was treated by radiofrequency ablation with a good evolution. This is how to manage the PVC. The catheter ablation is proposed when the PVC burden is more than 10% with the left ventricle ejection fraction impairment, right ventricle outflow tract or left ventricle outflow tract locations, or aortic root, epicardial papillary muscles if no response to drugs. The drugs used are beta blockers, calcium channel blockers, and or flecainide, propafenone if normal left ventricle ejection fraction, amiodarone if left ventricle ejection fraction impairment. Another case about inappropriate sinus tachycardia induced cardiomyopathy with severe functional mitral regurgitation and successful treatment with ivabradine. It concerns a woman, 72 years old, with asthma, chronic bronchitis, who presented dyspnea. The heart rate was 126 beats per minute, low blood pressure. The ECG shows sinus tachycardia. The chest X-ray shows cardiomyopathy and pulmonary congestion. The echocardiography shows reduced left ventricular ejection fraction and severe functional mitral regurgitation. The coronary computed tomography and MRI shows no abnormalities. The diagnostic was inappropriate sinus tachycardia with heart failure, and the treatment was with diuretics and ivabradine, 2.5 milligram twice a day. The heart rate decreased from 100 to 60 beats per minute. The systolic blood pressure increased from less than 80 mm Hg to 100 mm Hg, and losartan started. Left ventricular ejection fraction has improved from 29% to 46%. This is how to calculate the ideal heart rate. It's equal to 93 minus 0.13 by deceleration time of the E wave, calculated by echocardiography and pulse Doppler on the transmittal flow. This is the ECG on admission. There is a sinus tachycardia, and this is the ECG after ivabradine treatment. This is the image of echocardiography in hospital. There is a severe mitral regurgitation which was reduced by treatment. Another case about dual ventricular response in dual atrioventricular nodal non-reentrant tachycardia. It concerned a woman, 45 years old, who presented palpitations and fatigue persisting for the previous 3 years. On echocardiography, the left ventricular ejection fraction was 45%. The ECG and electrophysiological study shows dual atrioventricular nodal non-reentrant tachycardia. The patient was treated by ablation of the slow pathway with a good evolution. This is the ECG. After each P wave, there is 2 narrow QRS complexes. Thanks for watching this video. If you like it, please subscribe to my channel. See you soon for another video. Bye.